So my main focus will be on the new diagnosis, NIFT-P. And I've tried to make it a bit broader because the origin of defining the new pathological diagnosis NIFT-P lies in the fact that NIFT-P is a new pathological diagnosis where patients that have a NIFT-P tumor have a very indolent tumor and have a very good prognosis, and it should be, I'm going to tell you that it is doubtful whether this patient should have an aggressive treatment. So one of the motivations actually was to de-escalate the treatment of thyroid cancer. So this is a paper in the New York Times. I can't read when it was published, but probably around 2015 or 2016 that this was published in the New York Times, called "It's Not a Cancer, Doctors Downgrade a Thyroid Tumor." So NIFT-P actually is a non-cancerous diagnosis. That's the idea. Can we call NIFT-P a cancer? If we look a bit broader what the origin is, why did we reclassify this tumor? We see a worldwide trend in de-escalating the treatment of well-differentiated thyroid cancer. And as you can see here, and as you all know from also South Korea, we see the incidence going up, but the mortality is the same. And you see the graphs that we present from Holland on the left side of the slide. We also have an increasing incidence. This is a very interesting slide. This is the country of our neighbor, Belgium. And Belgium is even smaller than the Netherlands, but they managed to have two languages in one country. And the northern speaks a bit like we do, and the southern people speak French. And what you see is that there's, in this small country, a difference in incidence of thyroid cancer. It's very interesting. How is that possible? The reason is there's more imaging. If you do more ultrasound, you find more thyroid cancers, and then your incidence goes up. That's a problem, because actually we want to help people, extend life, extend quality. That's what we want as doctors. But if you do a lot of ultrasounds and find a lot of patients that usually would have died with the tumor instead of because of the tumor, then you can question whether we are doing our work properly. So we say it's an epidemic of diagnosis, not an epidemic of disease. And that's what we see, what I just mentioned in South Korea, when they started screening. So maybe we should say stop screening thyroids, reduce treatment invasiveness, this is what I'm going to talk about, de-escalate, and reconsider the diagnosis. And that's what I think NIFT-P from a surgical point of view is about. Is it truly thyroid cancer? What should we do with this patient? So, if we look at the de-escalation, I'm not going to go too deep into this topic, but I thought it was nice to mention, is that more and more, I don't know if you know this guy, but this is Dr. Miyachi. He's from Japan, a very well-renowned thyroid surgeon from Kobe Hospital, and he has a large cohort of patients that he has been observing for decades already with small thyroid cancers that he does not operate. So he operated, in this cohort, he operated around 1,200 patients. He surveyed 1,200 patients, and he operated about 900 patients. And he only had, in the whole series, 6 recurrences, and eventually 94 patients had surgery, because when the patients were included in the series, they were agreed upon that if they wanted to have surgery somewhere down the track, that they could have it any time. So there's about 50 patients that eventually choose for surgery after all. 27 of them eventually had a tumor growing, and a couple of them had lymph nodes and got their operation. And the interesting thing is that those patients afterwards were cured, but they had only one operation instead of maybe first a hemothyroidectomy, then a completion, and later a lymph node dissection. So it's an interesting way of approaching the disease. And this is for the, of course, for the micropapillary thyroid cancers I'm talking about. But also from New York, from the endocrinologist Tuttle, he has published a large series showing de-escalation of the small thyroid PTC cancers. I don't want to go too deep into this topic. I just want to show you that this is all part of a de-escalating trend that we see worldwide in the treatment of papillary thyroid cancer. So you could say that if you want to de-escalate, this was discussed this morning as well, that you, for instance, for PTCs, you would do active surveillance instead of a hemithyroidectomy and closely observe those patients. And maybe for in the future PTC between 1.5 and 4, we only do a lobectomy and then observe the patient as well. But there's still in Holland as well a lot of discussion going around. This was just the introduction. This is actually what the talk is about. It's about this paper by Yuri Nikiforov showing that a large project worldwide showing that there is a reclassification of a pathology diagnosis. Revision for encapsulated follicular variant of papillary thyroid carcinoma. A paradigm shift to reduce overtreatment. So this is also the incentive of organizing this was that there was a lot of people with expertise that said, listen, aren't we treating too aggressively for this subtype of cancer? So it's about a non-invasive follicular thyroid neoplasm with papillary-like nuclear features, NIFT-P. I will go on that more deeply further down the track. So his motivation, he writes in the introduction, is the rapidly increasing costs of thyroid cancer, and the National Cancer Institute organized a meeting where they said, listen, we have to see whether some cancers should be reclassified, and that's how this whole plan started. So then apparently they looked at thyroid cancer and said, hey, if we look at the follicular variant of PTC, FV-PTC, maybe we should reclassify those patients. So this tumor has been recognized since about the 70s and was composed of neoplastic follicles rather than papillae, and with follicular cells showing nuclear fissures characteristic of papillary thyroid cancer. And you can stage these two substages, infiltrative or non-encapsulated, or on the other side, encapsulated. So it's quite confusing. So this is the follicular variant of PTC, and you can classify it in encapsulated and non-encapsulated. So going further with the encapsulated variant of papillary thyroid cancer has an indolent behavior, and that's why they were thinking about the reclassifications. Most of those patients continue to be treated similarly, of course, to the normal PTC, and therefore they were wondering whether we could prevent the morbidity of the treatment, and also the patients that think they have cancer while they might have not. This is truly a pathological dilemma, but the diagnosis creates a lot of social problems. So encapsulated follicular variant of PTC has increased in the last decade 2-3-fold, and people estimate that maybe 10 to 20% of all thyroid cancers might be can be classified as this tumor, which is a lot, I would say. It's a challenging and controversial diagnosis, and therefore, of course, for pathologists, if you offer a pathologist a specimen like this, there's a large heterogeneity in giving pathology diagnosis, so that's the problem. A high inter-observer variability. So the project of Nikiforov was therefore, I think, very complicated. I have deep respect how they organized this trial. So their goal was to look at thyroid tumors currently diagnosed as non-invasive encapsulated follicular variant of PTC. I will repeat it all the time, have a very low risk of adverse outcome, and that was the drive, and the incentive was to give that another name so that we as clinicians know that we have to do with a very indolent tumor. So this is the way how they define the algorithm. So first, I would just go a little bit with you down the track. They look whether it was encapsulated or well demarked. If it was, they would say, if it wasn't, they'd say it's an infiltrative follicular variant of PTC. Then they would go further. Is there capsular or lymphovascular invasion? Yes. Also, drop it out of the box. Then no. If there's more than 30% of solid insular tubercular or more than 1% of papillary pattern, psammoma bodies identified or toll cell or collinear cell variants. No. Then we would go further, predominantly follicular patterns. Yes. Tumor necrosis, also excluded. More too high mitotic index. Patient also goes out. Then you go further. Nuclear features of papillary thyroid carcinoma, yes, NIFT-P. So what you see is they have the nuclear features that are really classical for papillary thyroid cancer, but all the other sort of malignant-like features should be excluded to have this diagnosis. So I'm glad I'm not a pathologist because it seems quite complicated to me. And this is to give you a bit more of an image, because when you focus on the nucleus, then you can also define on size and shape, on membrane irregularities and chromatin features. And those features, they can take points, and with those points you can eventually set the diagnosis for a NIFT-P. They also did a lot of, in this trial they looked, of course, at the pathologists who were internationally represented, did a molecular analysis. And this is a quite interesting slide where they actually showed that papillary microcarcinoma often has a PRAF mutation, and it goes towards classic PTC. The growth pattern is papillary, and then you have the follicular growth pattern, and you have a RAS mutation, and that's where you actually should position the NIFT-P, moving towards invasive, encapsulated follicular variant of PTC. And those invasive ones are not to be called NIFT-P. That's the hard thing, to select those out. It's just what I explained to you how you can do it. And then of course there's the follicular growth pattern with the RAS mutation, showing the follicular adenoma moving towards a follicular thyroid carcinoma. So this is actually, in Australia they would call this the money slide of the talk. If you remember this one, then that sort of explains the title of this talk, how you should position NIFT-P. So there was a reclassification, there was an international group of experts. Again, I will want to emphasize what the logistic challenges were of these studies. And they reviewed a set of cases with a long follow-up, of course. That's probably the most important feature of the study, because we want to know how the behavior of the tumor is. International multidisciplinary retrospective study, 109 patients with non-invasive EFV-PTC. And from now on I will use the abbreviations if you don't mind. And then they observed it for 10 to 26 years, and retrospectively of course. And the other group was 101 patients with invasive EFV-PTC, and they observed the patients for 1 to 18 years. So they reviewed the histological slides at 13 sites in 5 countries, by 24 thyroid pathologists from 7 countries. And they had a series, it says in the paper, of telephone conferences. I can imagine that those were long conferences, and they were used to establish a consensus for the diagnostic criteria they used. So as I said, 24 pathologists independently reviewed the scanned slide and then provided their diagnosis. And then they registered all those diagnoses and had the consensus after the telephone meeting. And then finally, of course, you can't go without a meeting. They had a meeting in 2015 in Boston, and then they discussed all the results and designed a new name. The main outcome measures they looked at were, of course, adverse outcomes, including death from disease, is very low, of course, distant or local regional metastases, and structural or biochemical recurrence, and patients with non-invasive and invasive NIFT-P diagnosed on the basis of the set of the histopathological criteria they defined together. All of the 100, these were the results. So all of the 109 patients that were classified with non-invasive EFPTC, 67 of them were already treated only with lobectomy, none received radioactive iodine ablation, were alive with no evidence of disease at final follow-up. So none of them had disease at the time they were followed up at this stage. In the 101 patients with invasive encapsulated follicular viral NIFT-PTC, an adverse event was seen in 12 of the 101. So 12% of the cases of invasive EFPTC, including 5 patients developing distant metastasis, 2 of whom died of the disease. So you see the difference in biological behavior. But of course, 12%, although of course terrible for those patients, but 12% is still very low. So you see how even in the behavior, how difficult it is to differentiate between these two. Here you see in the table represented what I just told you, adverse events 12 and the other one 0, and the groups were less or more comparable. So in addition, NIFT-P, on the basis of a careful examination, the tumor had a recurrence rate of less than 1% within the first 15 years. A large proportion of NIFT-P in the study underwent lobectomy. Only one received and none received radioactive iodine ablation. So one way or the other, the clinicians that treated those patients must have known already that it wasn't really an aggressive tumor, because you see that the treatment already, even though it's retrospective, has been executed differently. And the management of patients with NIFT-P can be de-escalated, is what they advise, unlikely to benefit from immediate completion thyroidectomy and radioactive iodine. So here's where they go into the therapy discussion. So here you see, this is a nice graph where you see how the diagnosis of NIFT-P affects the malignancy rates. So this is another paper published in the Annals of Surgical Oncology in the year after the publication of the classification. And they say that, of course, the definition of NIFT-P decreases the rate of invasive carcinoma following thyroidectomy. So the majority of these lesions were identified in patients with indeterminate preoperative FNA cytology, which I think is an interesting finding. So if you look at these slides for the Western series and the Asian series, you can actually see that NIFT-P here in the Western series makes out 15 to 20% of the well-differentiated thyroid cancer population, which is a large share of the total amount of patients. And in the Asian series that were published, this was a bit smaller, really almost 5%. So if you reclassify this tumor, there's actually a large effect potentially on the amount of treatments that we give. Then I found an interesting theory, because maybe you would think if NIFT-P becomes larger, then it might be more aggressive. In this series, they deny this. So they collected with 4 hospitals data between 1982 and 2015. They did the whole NIFT-P reclassification again, and they found 79 cases with tumors larger than 4 centimeters. And the average time of follow-up was 5.8 years, so maybe not so long as in the other series. And a total of 42 patients of the 79 had radioactive iodine therapy. And radioactive iodine group usually, of course, have tumors larger than 5 centimeters. And if you look at the long-term outcome, even for this group of patients with tumors larger than 4 centimeters, we see that they also have an excellent prognosis without metastatic potential. So this group advised aggressive management is not recommended for NIFT-P tumors, but patients should have continued follow-up. Well, I think that's a wise advice to follow up. So, in summary, thyroid lesions currently diagnosed as non-invasive encapsulated follicular variant of PTC, distinct class of thyroid tumors with a very low risk of adverse outcome. These tumors should from now on be termed non-invasive follicular thyroid neoplasms with papillary-like nuclear features, NIFT-P. The reclassification of this tumor affects more than 45,000 people worldwide. It reduces psychological burden, medical overtreatment and expense, and other clinical consequences associated with the cancer diagnosis. So, what are we going to do? I haven't been able to find a new protocol, but integrating these results, I would say if you have a thyroid tumor and you do a hemithyroidectomy and it says the pathological diagnosis of NIFT-P, then I would say stop further treatment, keep the patient in follow-up. You don't have to do a completion of thyroidectomy, and I would say don't give the patient radioactive iodine. Implications for the future: it might reduce the complications that we have with performing total thyroidectomy. Risk, of course, although they are very low, of secondary tumors following radioactive iodine that we don't have to supply anymore, and the reduction of costs of healthcare. And only if we look at radioactive iodine, we would be able to save between $500 and $8,500 per patient. And decreased long-term surveillance would account for another substantial proportion of cost reduction, because follow-up, of course, is also not for free. This was this slide I want to close with, that I came across into the Lancet paper describing the basis of curiosity as a basis for our science. And I think it's a very interesting article to read, because this paper describes how there is a declining interest from clinicians to perform research. And one of the drivers of this main highly impact study was a clinical curiosity. So I want to call upon you to all be involved in research and combine it with clinical curiosity, and then we can reclassify these type of diseases and give the appropriate treatment. Thank you very much for your attention.